This is the 91st edition of the Psychcast. This week, we have a best of highlight reel of former episodes to share with you for the Thanksgiving holiday. For MDedge, I'm Nick Andrews. Before we get going on this best of episode, I'd like to invite you to take our listener survey to help make this Psychcast a little better. So if you have thoughts on how we can improve or feedback on the show, please follow the link in the show notes. Coming up later on this episode, we're going to review some of our conversations from the 2019 American Psychiatric Association annual meeting in San Francisco. That was back in May. The episodes we'll be checking in on will include suicide crisis syndrome, prescribing clozapine for patients with refractory schizophrenia, psychiatry in primary care, medication disruption for patients during things like natural disasters, and prescribing benzodiazepines. If you like the conversations you hear today, you can find links to the original full episodes in the show notes. And a reminder, the link in the notes will take you to the official MDedge Psychcast website, but you can navigate to any podcast app such as Apple Podcasts, Spotify, Pandora, Overcast, or even YouTube once you're on the website. And now, this week in psychiatry. This week in psychiatry, vaping was a key issue in the first confirmation hearing of President Trump's FDA nominee. Dr. Stephen Hahn faced questions from both sides of the aisle with regards to youth vaping. However, the radiation oncologist came short when he was asked to commit to taking action, particularly banning flavored vaping products. Dr. Hahn spoke at a hearing on November 20th before the Senate Health, Education, Labor, and Pensions Committee. Dr. Hahn said that youth vaping is an important and urgent crisis in this country. He also said that he does not want to see another generation of Americans become addicted to tobacco and nicotine. Senator Pat Murray is the ranking member of the committee. She asked if he would work to finalize a ban on flavored e-cigarette products that was first proposed by the president back in September of this year. That ban has since been walked back. Dr. Hahn responded saying that he is not privy to decision-making processes, but that he very much agrees and supports the idea that aggressive action needs to be taken to protect children in America. When pressed by Senator Murray as to whether he told President Trump that he disagrees with the decision to back away from the ban, Dr. Hahn revealed that he has not had a conversation with the president. Senator Mitt Romney warned Dr. Hahn that the playing of politics would be unlike anything he has ever seen. He went on by saying this is already being played out in the lobbying of the administration to change its stance on flavored e-cigarette products, which can run counter to the science about the harmful effects of these products. Mr. Romney noted that the question is how Dr. Hahn will balance those he puts forward. He said that how Dr. Hahn deals with this issue is a pretty good test case for how he would deal with this issue on an ongoing basis on matters, not just matters related to vaping. Senator Romney pressed further by citing evidence that flavored vaping products are a gateway to youth nicotine addiction. Dr. Hahn responded by saying that he was familiar with that research and that he will use science and data to guide decisions, but he stopped short of committing to a ban. Outside of vaping, much of the senators' questioning was non-confrontational, with questions spanning a gamut of issues facing the FDA. Dr. Hahn offered his commitment to working with Congress to address drug shortages, noting non-specifically that there are things that they can do to help. He also pledged to work with Congress on addressing patent reform to get more biosimilars to market in an effort to help drive down drug prices. Regarding opioids, Dr. Hahn was asked about balancing the needs of those who legitimately need access to opioids against abuse and diversion. Committee Chairman Lamar Alexander said that he plans to schedule a vote to advance Dr. Hahn's nomination on December 3rd. And that concludes This Week in Psychiatry. Remember, you can find news like this and more at mdedge.com/psychiatry. We'll be right back with the first portion of our Best of episode featuring Dr. Igor Galynker in a conversation on suicide crisis syndrome. Welcome back to the Psychcast by MDedge. I am Nick Andrews. Up first in this Best of Thanksgiving episode is Dr. Igor Galynker talking with Dr. Lorenzo Norris about suicide crisis syndrome.
First one is affective discontrol, and it comes in several forms, and the most intense one is emotional pain, which is very distinct from physical pain, although it's mediated by the same brain areas, actually. And when you ask a patient, are you in pain, meaning mental pain, they would know immediately what you mean if they have it. And then there is a severe panic with frantic component to it, franticness and agitation, with some dissociation, rapid mood swings, okay, even some happiness, and but also some depression and despair. And by rapid, I mean minutes. And that's called depressive turmoil. And finally, acute anhedonia. And it's an ability to be experience pleasure in somebody who was able to do it and now cannot even imagine what it's like. So that's criterion 1B, and affective discontrol. The second criterion is what's called loss of cognitive control. And the most severe manifestation of it is ruminative flooding. And that is when your thoughts are you feel like you're being sucked in by ruminative negative thoughts into a vortex and you cannot get out. And that is associated with actually headache and head pressure, and sometimes people feel like their head is going to explode. And with that, there's ruminations. Cognitive rigidity is very important, like inability to change a perception or response and seeing an alternative to your life situation. Like if you feel that you cannot get your job or you lost a job, you cannot see or even imagine that there could be another job. If a woman left you, you can't imagine there will be any alternatives. So that's regardless of what anybody says. And then there's an ability to suppress the thoughts. And the way it works is that if you ask somebody, do you feel like you can control your thoughts or your thoughts control you? I mean, when they say the thoughts control you, that actually elevates suicide risk. And the other two are kind of more intuitive and more familiar. One is the over-arousal, insomnia, and agitation. And the fourth one is social withdrawal, which is manifested by kind of disconnection from friends, and also evasive vague communications when people stop responding directly with you're saying, kind of withdraw. So you need to have both criterion A and one of each criteria B to meet the syndrome. When somebody does, then the predictive validity for suicidal behavior within a month, regardless of when somebody says they're suicidal or not, is about 13. And we replicated that. And I'm sorry, I forgot to mention a critical thing, and it is that the suicidal ideation is not part of the syndrome. And the reason for that is not that people do not consciously feel suicidal, but some may not until the last second, some may never, some would hide it from you intentionally because you would prevent them from achieving their goal, and some do not have it yet. And that's why it's unreliable. In fact, in the CDC study that came out last summer, the day Kate Spade actually killed herself, I may have even mentioned it in one of my podcasts, the 75% of people who died by suicide denied suicidal ideation. So if we ask people about suicidal ideation as our gateway question, we miss 3/4 of people who would take their lives.
We've talked about the suicide crisis syndrome, and one of the things that I have continually been struck by is when you speak about this last point of suicidal ideation. I think of the dilemma frequently clinicians are in terms of, just to say, a standard outpatient practice, if you will. Some of my colleagues and I were talking about this yesterday and asking about, are you suicidal? Are you having suicidal thoughts? One of the most powerful or interesting things I think about the suicide crisis syndrome as I look at it is, again, you're not actually asking whether or not you are suicidal. You are constantly looking at and assessing, if you will, these different criteria. So you're not relying on the patient's direct report, which, as you have already indicated, we know can be challenging or unreliable, just to be point blank about it. So, but it just really is it's such a change in terms of how we think about suicide and how we approach and collaborate with our patients. And in fairness to not in fairness, but the other part about the patients themselves may not even be aware that they are in this state and we are assessing it. And I just find that just a powerful paradigm shift. Whenever we think about suicide, we most of the time always start with the idea of like suicidal ideation, and this is just a very different framework in terms of approaching it.
If you enjoyed that conversation, you can find the complete episode in its entirety in the show notes. And now we move on to this interview with Dr. Jonathan Meyer about prescribing clozapine for patients with refractory schizophrenia.
So I myself just wrote a handbook on how to use clozapine, which is now being published at this year's APA meeting from Cambridge University Press. It has the clever title, The Clozapine Handbook, but the important thing is very systematic in going through each of those types of adverse effects and issues that people confront when prescribing clozapine. And so now people have a resource to go to along with whatever support they can get within their own institution or their own country to have the information at their fingertips to prescribe clozapine.
You know, Dr. Meyer, I'm glad you brought that up in terms of the adverse effects. And I wanted to talk a little bit about those. And I think most clinicians are fairly familiar with the agranulocytosis, leukopenia, things of that nature. And I would, just from experience with, if you will, second-generation antipsychotics, many people may have a little bit more comfort with weight gain, insulin resistance, if you will, the development of diabetes. Now, one thing in particular about clozapine, I personally have never seen a patient with this, but it's the myocarditis. I mean, have you encountered a patient who's had that? And is that like one of those things that you are always vigilant about, even though it is a very rare side effect?
So this is something which has been reported seemingly much more so in Australia than any other country, and this may be related to monitoring and some early cases. We don't really know what the true rate of myocarditis is. It ranges from a fraction of a percent to as high as 3% in Australia. Mm-hmm. People worry about this, but in the past they didn't have a full understanding for what were the reasons to suspect myocarditis, and often they unfairly thought that anyone who has an early fever must have myocarditis. But unfortunately, that's not true, because fever is not uncommon. Maybe 20% will have fever in the first few weeks of treatment, but we think the rates of myocarditis are a fraction of that. So in the book, I discuss the literature on this, and I provide what I think is a rational monitoring scheme based upon the fact that if you have myocarditis, almost all the cases will have a troponin level more than 2 times the upper limit of normal. And I think this is not an unreasonable thing to throw in only for the first 6 weeks. There have been virtually no cases of myocarditis after day 42, and almost all of them are in the first 21 days. So I think it's not unreasonable to say, we're going to add a troponin and also a CRP.
So you would add a CRP also along with the troponin?
There was a small number of cases that were reported in Australia. The world's expert is Kathleen Ronaldson from Australia, and they found a few cases where the troponins didn't quite meet the threshold, but the CRPs were more than 100. So everyone's getting stuck weekly. The first 6 months anyhow. So to throw in those couple of extra labs, and again, it's only for 6 weeks, because once you're now at week 8, myocarditis is no longer part of the picture. And so this is a way for people to keep an eye on that, and also to understand that while fever is very common, and yes, you would want to hold the drug while you're doing the fever workup and getting the troponins if you haven't had it, that most of the people who have fever have nothing but fever, and then can be restarted under clozapine.
Now, one other thing that, in my opinion, comes up with many of our patients, but quite frequently, is the issue of smoking. And smoking and tobacco use obviously can affect the clozapine levels. I don't know if you have a view or a thought on that in terms of patients who, if for some reason you cannot assist them in smoking cessation or things of that nature, if you have thoughts in regards to best practice advice in terms of if people are using tobacco and attempting to take clozapine.
So what I usually say is that being ill is stressful enough. Starting clozapine may be part of that. So if they're smoking at that time, I would say that's probably not the time to stress them out by insisting on smoking cessation. Now, as you mentioned, smoking induces the cytochrome enzyme P451A2, and very specifically, it's burning the tobacco leaf or the cannabis leaf. But if you're vaping, you don't induce because you're not burning anything. And so that's important to know. People say, I vape, they're not inducing their 1A2. So that
is important to know, because vaping is quite out there now.
Yeah, so some people are vaping, but they're not going to be inducing their 1A2. They have to be burning a leaf, whether it's tobacco or cannabis, whatever. But assuming they're smoking, that's why we often say in the world of clozapine, it's best simply to monitor treatment via plasma levels rather than going by dose, because there's so much biological variability as well as that introduced by the smoking habit itself. The threshold for response for most people who aren't responding, we would say at least get up to at least 350 nanograms per ml for a clozapine level. Now, that's not a guarantee of response. Just because your level is 400 doesn't mean you should be a responder. Maybe your brain needs a level of 600 or 800 or 1,000 if it's tolerated. But at least you know you're in the game once you get above 350. But that's why you check levels. Because you just want to say, look, if this person's not getting better, am I even in the ball game? And if I'm not, let's get it up of 350, and then we can move along from there.
In our third interview of this Best Of episode, we will join Dr. Cam Ritchie with Dr. Lorenzo Norris. Their topic today is how natural disasters can impact and disrupt medications for psychiatric patients.
And I will say that disaster planning has come a long way, I think, over the last 30 years in the U.S. and all of the disasters we've had, 9/11, Katrina, Maria, we've learned. But unfortunately, the disaster planning usually focuses on, quote, regular medications, and usually psychiatric medications are barely thought of as not, if at all. So there's supply chains. There's supply chains for groceries and for fuel and for medications, but they presuppose that there's going to be somebody who's going to have the supply and the way to get it to the affected areas. And of course, with Maria down in Puerto Rico, it was very hard to get supplies in and out. And even a place like Houston after Harvey, because of the floods, it was logistically very difficult. I'm not sure if you're aware, Dr. Norris, but in the CDC stockpiles of medications, they don't stock psychiatric medications other than Valium, which is there in case of nerve agent attack.
I was not aware of that.
There's a lot of focus on infectious diseases and vaccines, but one of my advocacy points is that we need to get this to higher levels so they will think about having some medications. Now, when I worked for DC, I was able to influence the formulary there to make sure that we had enough. And I'd recommend anybody hearing this to work with their planners on the state and local level to make sure that they are thinking about psychiatric medications. And often you get this sort of, doc, that's interesting. I never thought of that. Maybe we ought to have some more consideration.
Well, that's I did not know that about the CDC, Dr. Ritchie. That's actually fascinating to me. You would think, given the demonstrated mental health burden that the country faces, the amount of patients taking psychotropic medication, you would have just naturally assumed that there would have been some supply, but assumptions are dangerous.
Psychiatry is always the red-haired stepchild of medicine. And again, the focus in past years was on infectious diseases and major trauma and surgery. But now, as we, in general, like infectious diseases in general, measles and others keep coming back, we really need to make sure that they're thinking about the psychiatric medications.
Now, Dr. Ritchie, you mentioned in terms of advocacy, and I was wondering if you could maybe share with our listeners, one, how you got interested in disaster psychiatry or the aspects of disaster. I mean, people who don't know Dr. Ritchie's had a very incredible career. Could you share with us a little bit about how you got into the field of disaster psychiatry and why it is very important for you to remain as an advocate for issues such as this?
So I started before disasters. I started as a military psychiatrist. I was in the Army for a career, and I was in the Army, frankly, because they paid for medical school at George Washington. Best decision I ever made, but that's another story. And so when we deployed to places like Somalia, I began to think about what psychiatric medications I would bring, what would be needed if you're in an austere environment. So you shouldn't be on lithium if you're in Iraq or Somalia because you can't get lithium levels. You're going to get dehydrated. On the other hand, you may need some Haldol for the acute psychotic reactions. And when I went to Somalia, Prozac fluoxetine was just coming in, and that actually was very useful because it had a long half-life. So transition forward, I was on active duty at the Pentagon when 9/11 hit, and so we were looking at helping. I worked the Pentagon and was very involved with coordinating disaster response there, and we looked at, again, principles of military psychiatry. And then I did a fellowship in disaster psychiatry, actually the first fellowship at the Uniformed Services University, and I've maintained interest. I think the field has come a long way. Remember, we used to do critical stress debriefings, and now we do a lot more that has to do with early intervention, psychological first aid. But the question about psychiatric medications is, again, often neglected. So that's why I'm circling back to that and the importance of that area.
It's just hearing you actually speak about it from military psychiatry and thinking about what medications essentially work in very hostile territories or zones. It also makes me, again, going back to this idea of preparing for a disaster. It's not just even strictly having the supplies, but particularly if you're in a prolonged situation where there's just not going to be access to resources, you need to think about alternative medications and what works, what doesn't require levels, what can you effectively take with minimal resources. And until you actually set it like that and put it in that framework, I was like, of course, why wouldn't you think that way? But it was interesting until you said it like that. It literally took that for my mind to actually think that way, because I still think snowstorm and like, well, Harrison Teeter, or Whole Foods will open eventually or something like that, or CVS. But that's an interesting way to think about it.
To give them sort of a booster, right, or more education in behavioral health or psychiatry is going to be important. The problem is right now, right, for internal medicine, let's just look at internal medicine docs. So 3-year residency program, and there's really 0 minutes. Zero minutes required, right, for these internal medicine residents to have clinical psychiatric instruction during those 3 years. Now, you may ask why. I'm assuming you're going to ask why, because I can see the look in your eyes, right? And here's the bottom line. There's just not a lot of time.
You don't have a lot of time.
There's not a lot of time. 3 years, right? They got to learn about the heart, the kidney, right? Then there's that liver, right? And so there's a lot of other organ systems that they have to learn. They got to get them down. They got to learn about how to deal with hypertension, osteoarthritis, various types of chronic pain for which they see, most of these patients have, a lot of these patients have chronic pain issues. So there's no requirement. In the state of California, physician assistants, PAs, right? PAs, deliver a lot of primary care in the state and throughout the country. California, 2 weeks. 2 weeks is the minimum amount of time that they have required to get some clinical instruction in psychiatry, right? For family medicine, it's a little bit better. For OB, it's pretty much nil. And so this is an issue.
This is a
huge problem.
Huge issue. Yeah. And when you talk about our colleagues in primary care or family medicine, at my school, Gito School of Medicine, I've been asked at times to lecture or speak to our primary care residents. One, I want to say I was blown away by their dedication to service of their patients, but here was the second thing. I started to talk to them, and there was literally no difference in terms of many of the things that they were going through than what our psychiatric residents were going through. But here was the thing, and hopefully people in the audience, depending on where they trained, had the same thing. We had a process group or a T group or something of that nature, which helped us understand and deal with the rigors of the field and how we understood ourselves, and that was key. These residents in primary care, they didn't have that. They were getting overwhelmed, not by, if you will, the heart or the lungs. It was all, if you will, mental health. And I could just, when I started talking about what I consider very basic principles, just in terms of process and how you work with a patient that's suicidal and handle your own emotions, it was like, I just invented the wheel. So back to your point, Dr. McCarron, there just isn't enough time really for most residencies to effectively incorporate, what I won't say we take for granted in psychiatry, but those areas. So I agree with you. And also I tell people all the time, my sister-in-law, who's an OB-GYN, prescribes far more antidepressants than I do. And I have no idea where they found the time to get any type of training. So I concur with a lot of what you said.
Well, let me be provocative, and I can speak a little bit authoritatively here, as I'm an internist, right?
Okay.
So I'm also a psychiatrist.
Okay.
I did one of those combined trainings.
Okay.
Yeah, I'm one of those combo
You're
folks.
a combo guy.
So I know what it's like to live in the primary care setting. And let me just emphasize that PCPs are heroes. They're heroes, right? They're seeing patients quickly. They're seeing complex cases. They're seeing patients who have multiple general medical and psychiatric issues. But let me just say this. I mean, so about 80% of all antidepressants prescribed in this country are prescribed by non-psychiatrists.
Say that all people do not. I keep telling my colleagues. I'm sorry. Go ahead.
I'm the same way. It's like what So, but they're prescribing this stuff, right? About 60% of all mental health care delivery in this country is delivered by non-psychologists, non-social workers, non-MFTs, non-psychiatrists. This is delivered in the primary care setting.
Yes.
On any given day, on average, about 40 to 45% of patients seen on a Monday, a Tuesday, a Wednesday, a Thursday in a primary care office is centered around behavioral health
Absolutely.
issues. Significant psychiatric issues like depression, anxiety, substance use disorders, etc. So they are on the front lines. They're already there in the underserved areas and otherwise, but they're there doing it. They're there. And they're the de facto mental health care delivery system. Bottom line, big picture.
And you know what? A lot of people wouldn't like to hear us say that, but that just is what it is. I've said that it's reality. It is reality, and they are the front line, and they are the de facto system. Because I would argue that many patients would have a very difficult time getting in to see a psychiatrist, let alone I'm talking an adult psychiatrist, let alone a child and adolescent psychiatrist in a timely fashion. So that, whether people like it or not, that's just what it is. That's just basic fact.
Yeah. So we have, these folks providing 60, 65% of all mental health care delivery, but guess what? They didn't get the training.
Yeah.
Those internists didn't get the training. The PAs in the state of California got 2 weeks of training, right? And so, but they're delivering most of this care, much of it very complex. And so really, to set this up, we have a situation where we don't have enough psychiatrists. We don't have enough psychologists either, by the way. But we don't have enough of these specific providers. The primary care providers are delivering all of this care, yet the training is limited, right? It's limited. It's certainly much more attenuated relative to what we see in psychiatry. So that's the issue. That's the problem at this point.
So let's then talk about, we've got an idea of what the problem is. So I guess, yes, you and I are going to come together in 5 to 10 minutes. We're going to give the audience a solution that's going to solve this problem. I am joking, of course.
And finally, today in our APA Best of Thanksgiving episode, we join Dr. Richard Balon in talks with Dr. Lorenzo Norris about prescribing benzodiazepines.
And I remember a long time ago, much younger man, and people were telling me, oh, you should not keep people on benzodiazepines for a long time. I had a patient, for instance, I remember her till these days. On lorazepam, 5 milligrams a day, everybody was like shaking their head. She stayed on a stable dose for 5 years until she disappeared from my practice. She moved somewhere or whatever. She was doing very well. There's nothing.
Well, it's interesting. When I think back to some of my patients that I have outpatient, and coming fresh out of training, similar to others, you're pretty much trained not to keep someone on a benzodiazepine long term. And I was really surprised by the number of patients, because, when you first start out, you inherit patients, so to speak.
Oh, yeah.
How many patients have been successfully sustained on, I'd say, a low dose of Klonopin for like a decade or more, and without raising it, without increasing the dose? So, we talk about treating the patient. I just think that in certain clinicians, we need to think and assess, and some patients can actually be perfectly stabilized on, if you will, a benzodiazepine long term, even though it may not be your initial go-to option. I think it's very common, at least in terms of major depressive disorder, for clinicians to start an SSRI and then start a benzodiazepine and then taper the benzodiazepine off, and that's for a variety of reasons. Most SSRI-induced anxiety, comorbid anxiety, as well as sleep. But you won't necessarily see people again go directly to the benzodiazepine for generalized anxiety disorder, maybe for panic disorder, but I usually don't see folks do it for generalized anxiety disorder. Speaking of benzodiazepines and sleep, again, what are your thoughts about the use of benzodiazepines, Dr. Balon, versus the Z drugs?
Well, I think both groups are useful, but benzodiazepines for me add sometimes the quality of the when you use, for instance, we mentioned clonazepam, the long half-life, there is a little bit of anxiety calming during the day.
Mm-hmm.
So sometimes even, let's say you say generalized anxiety disorder with a patient on low dose of clonopin and the patient still doesn't sleep very well. Why would I use a Z drug? I would increase the nighttime clonopin and let's say do 0.5 in the morning and 1 milligram at night and they sleep well. Those are, though the benzodiazepines, which are not necessarily FDA approved for sleep, but we use different things in different indications. There are 5 benzodiazepines which are approved for sleep. Triazolam, estazolam, temazepam, clozapine, and flurazepam. People don't use them very much. They mostly use temazepam. But I think at some difficult cases I've used the clozapam and flurazepam, which are, they have a long half-life and difficult. But for instance, clozapam was specifically developed for sleep, not for anxiety, because it acts on a different alpha part of the benzodiazepine complex receptor. So these are interesting drugs for sleep too, and I think the added anti-anxiety things in that indication is fine. And I combine them definitely with antidepressants in depression, and sometimes again the carryover effect of the taking care of anxiety. We talked about it in the last podcast. Remember when we were talking about that depression can have a significant part of anxiety, and we don't count on that. It was not even in DSM until DSM-5 that it would say anxiety is part of depression, even though every clinician would say yes, it is.
Now, when we just talk about benzodiazepines and its use in, for instance, you brought up temazepam. One thing, putting on my residency training hat, if you will, from back in the day, is whether or not our current group of clinicians coming up are getting enough experience with benzodiazepines in terms of the breadth of how the variety of conditions they can be used in. I don't know if you have any thoughts about that, Dr. Balon.
Well, I do. I don't think they do have enough experience. I think there is a generation, at least in my experience, I'm a training director in my other hat, there are supervisors which clearly discourage them.
Right.
The very old guys will say, it's okay, try it, and so. But then there are people who would say, absolutely don't use it. There are some settings. If you go to some community mental health centers, benzodiazepines are no. And that the decisions are not usually made by physicians. That's the sad part of it. And if in some other settings, people have a lot of hesitations. And I understand that if you have, substance abuse population. But benzodiazepines are not abused alone, okay? Very rarely you can find somebody abusing benzodiazepine just per se. It doesn't give you any high, okay? It doesn't give you release your anxiety. There was a little publication by the APA in the 90s, which by the task force on benzodiazepine use, which actually addressed that issue, and I quoted it several times in different things. And so, people who are not abusing other stuff, I don't see a problem. Why not train the residents to treat these people with benzodiazepines? And even in some other indications, we have somebody who has abused stimulants.
Right.
They cannot sleep and everything. I'm not necessarily clear whether we should say benzos are absolutely no. I don't know. Where is the evidence? I'm just being a little bit provocative.
No, I think it's really starting to make me think, because this is a common scenario that we encounter. Just what you brought up in terms of the stimulant use, or a patient who has, if you will, had a substance use disorder of whatever type. People may or may not just automatically say no benzos, no controlled substances. And again, we don't have, our toolbox is a bit, somewhat limited in psychiatry, so we don't want to limit ourselves from medications that could potentially be effective.
And that concludes the 91st edition of the Psychcast by MDedge. For MDedge, I'm Nick Andrews.